In the previous section, we have discussed a lot on the dyshemoglobins and the basics of the pulse oximetry, but in the current section, we are going to discuss on more of anemia. That's what we are going to discuss. And this is going to be an interactive video on anemia and the basics of anemia, because there are a whole lot of subsequent videos that are coming up on anemia as well. So first of all, the question is, what is an anemia? That we're going to see. So if you ask me what do you mean by an anemia in the first place, I can clearly tell it is nothing but a decline in the number of circulating RBCs. Decline in the number of circulating RBCs. This is what we call as an anemia. But anyways, it's not always. Not all the time. But still, the basic definition of anemia is a decline in the number of circulating RBCs. But there are certain criteria to diagnose an anemia, which is given by WHO. Again, the values are very important. So what are the criteria for diagnosing anemia? There are two basic criteria. One is based on the hemoglobin and another is based on the hematocrit, both of which is given by the WHO. Out of which the hemoglobin based criteria is the most important. Let us see on the hematocrit also. The first thing, again, your criteria for anemia depends on the age of the patient as well. The first thing, I can tell in a child whose age is in the range of 6 months to 5 years. If it's 6 months to 5 years, for example, if it is less than 11 grams per deciliter, or if the hematocrit is less than 33%, you're going to call it as an anemia. Similarly, if it's a child whose age group is in the range of 5 to 11 years, then you can tell if it is less than 11.5 grams per deciliter or less than 34%, you can call it as an anemia. Similarly, if that same child is in the growth spurt period, that is in the range of 12 to 13 years, you can tell if the hemoglobin is less than 12 grams per deciliter or it's less than 36%, you can call it as an anemia. Next comes the beast. Females. With no offense, I told the beast because it's important for the exams, not because it's a female. So if it's a female and if it's an adult female, so first I can tell you about the pregnant and a non-pregnant adult female. So we can talk about the pregnant and the non-pregnant adult female. So if it's a pregnant and adult female, means if it is less than 11 grams per deciliter or if it's less than 33%, once again, if it's non-pregnant, means if it's less than 12 grams per deciliter or less than 36% of hematocrit, you can call it as an anemia. Similarly, if it's a adult male, if it is less than 13 grams per deciliter or if it's less than 39%, you're going to call it as hematocrit. At least minimum thing you have to remember for exams is these three things at least, because these three things are very repeatedly asked in exams regarding the definitions of anemia and the criteria for diagnosing an anemia. And similarly, I can also tell the criteria for diagnosing severe anemia. The moment I call the criteria for diagnosing a severe anemia, I can tell except these two categories. Except these two categories where the definition of severe anemia is less than 7 grams per deciliter, remaining every single thing is less than 8 grams per deciliter. So all the other things are less than 8 grams per deciliter forms the definition of a severe anemia in the first place. So once you have known about the criteria for diagnosing anemia, then we can discuss on certain diagnostic parameters on diagnosis of anemia. What are the diagnostic parameters? The first diagnostic parameter is the hemoglobin itself, which you have discussed on the WHO criteria. The second diagnostic parameter will be on the hematocrit, that is HCT. So this is what we are going to discuss. So what do you mean by an HCT? HCT is nothing but the cellular component. HCT is nothing but the cellular component of the blood. Cellular component of the blood. So normally, who is going to contribute to the cellular component of the blood if they ask you? It is the RBCs that contribute approximately 99% of the cellular component of the blood. Which means the changes in the hematocrit directly reflects the changes in the RBC. So what are the things that reflect hematocrit now, if you ask me? It's the RBC, yes, there's no doubt about that. But it's either the number of RBCs or it's the size of the RBCs that are going to determine the hematocrit. There are two classic examples for that. Both are important. That's what I'm trying to do. How you can tell both are important? There are two classic examples. First thing, if you tell in thalassemia minor, your size of the number of RBs will be increased. So if you ask me the number of RBs are increased, you might think that the hematocrit may be increased, but actually the hematocrit is decreased. That is because the RBCs in thalassemia are extremely microcytic. Here the microcytosis is so severe that the increase in the number of the RBC is not that, making an equal, equalization principle. So you don't get a increased hematocrit or a normal hematocrit. Instead you get a reduced hematocrit. That is because of the severe microcytosis of the RBC. Next thing, you might also get in another condition called a megaloblastic anemia. In a megaloblastic anemia, what you see is generally the increased mean corpuscular volume or increased size of the RBCs. So since the size of the RBCs increase, you might expect a hematocrit to be increased, but that's not true. Hematocrit is actually decreased in megaloblastic anemia because the number of RBCs here are decreased. So that is the reason why you have a decline in hematocrit in a megaloblastic anemia. Clear? So these are the difference in the hematocrit. If they ask you the normal hematocrit, finally somebody asks you the normal hematocrit, you can tell in females it is approximately 36 to 46% and in males it is approximately 41 to 53%. For all practical reasons, you can take an average hematocrit of approximately 45%, which is applicable for both males as well as the females. The next important thing, but a little bit of relatively dry topic, is the RBC indices and the reticulocyte count. RBC indices and the reticulocyte count. The first and the most important RBC index is the mean corpuscular volume. So that is called the MCV. So what do you mean by the mean corpuscular volume? So what do you mean by the MCV or the mean corpuscular volume? The MCV is nothing but the average size of a single RBC, which means you're going to take size of all the RBCs and take an average and find out the average size of a single RBC. That's what we call a MCV. So if somebody asks you the normal MCV, the answer is very easy. It is 80 to 100 femtoliters. And whenever you have a RBC size of 80 to 100 femtoliters, this is what we are going to call it as something called a normocytic picture. So if the RBC size is less than 80, I am going to call it as a microcytic RBC. And if it is more than 100, I am going to call it as a macrocytic RBC. And we have innumerable examples. You can still so many examples for that, which is not that important. Next thing what you're going to see is something called a MCH. That's called mean corpuscular hemoglobin. That's what is very important. So normal mean corpuscular hemoglobin is in the range of 28 to 34 picograms. That's what is very important. So this normal MCH of 28 to 34 picogram is what we are going to call it as a normochromic picture. This is what we refer to as something called a normochromic picture. If it is less than 28 picogram, I am going to call it as hypochromic picture. Or if it is more than 34 picogram, we are going to call it as a hyperchromic picture. Then finally you have something called a MCHC. So what do you mean by MCHC? Is the mean corpuscular hemoglobin concentration. So which means it's the average concentration of hemoglobin inside one particular RBC. That's called what we call it as a mean corpuscular hemoglobin concentration. If you ask me what do you mean by what is the normal MCHC, it is approximately 30 to 36 grams per deciliter, which is the normal MCHC. So which means MCHC is, you can see one value very clearly that it is actually more than what you see in the blood, isn't it? Because why? Because this is based on only the RBC content, isn't it? Hemoglobin concentration. It's not the blood hemoglobin concentration. Blood hemoglobin concentration means you are mixing with the plasma, which is the water side, isn't it? Fluid. So that is the reason why, because the dilution effect of the plasma in the blood, the hemoglobin concentration is actually less compared to what is seen in the RBC. That is the reason. So next you have something called a reticulocyte count. Whenever the moment you ask about the reticulocyte count, The reticulocyte count means that it is the measure of the erythropoietic activity of the bone marrow. It is a measure of something called erythropoietic activity of the bone marrow. So the moment you ask about the erythropoietic activity, you might ask me why the mature RBCs in the periphery do not reflect the erythropoietic activity. Actually, they do not, because mature RBCs are subjected to a lot of other problems in the periphery, like destruction, all these things. So they may not necessarily reflect the actual erythropoietic activity going on. For example, if you have a hemolytic anemia, you might have even accelerated erythropoiesis, which means the RBC count may be low in the periphery, but your erythropoiesis may be accelerated within the bone marrow. So your number of circulating RBCs may not be actually a true reflector of what is the erythropoietic activity within the bone marrow. So, but the reticulocyte count is definitely. So, what do you mean? What is the normal reticulocyte count? If somebody asks you, it is approximately 0.5 to 1.5%. But is it relative? Is it really true for all the cases? Actually, answer is no. It's not true for all the cases. Why it is not true for all the cases is because sometimes your reticulocyte count may not be a true reflector of what's going on within the bone marrow. So let us see a classic example where the hemoglobin is only 6 grams per deciliter and your hematocrit is only 15% and your reticulocyte count shows some value of approximately 2.5% maybe. Which means here you might think the reticulocyte count is actually higher than the upper limit of normal. You might think there is a good reticulocyte response and you might think there is a good bone marrow erythropoiesis going on. But actually this is not true, to be honest. Let us see why. Because reticulocyte count, how we are going to measure in the peripheral smear is by supravital stains. First of all, if you ask me how you are going to measure the reticulocyte count, is by using supravital stains. Is by doing something called a supravital stain, like a new methylene blue or brilliant crescel blue. So these are the stains that we use for doing a reticulocyte count. Since the reticulocyte count is actually measured by comparing with the surrounding RBCs. Suppose if the number of mature RBCs are reduced due to some reason, there is a lot of likelihood that the reticulocyte count may actually look relatively increased in number. So that is also highly possible. So that is the reason why, there is another index that you have to measure, especially in times of anemia, that is called a corrected reticulocyte count. That's called a corrected reticulocyte count, which is otherwise referred to as something called a reticulocyte index. So otherwise called a corrected reticulocyte count, otherwise called as a reticulocyte index. So the moment you call it as a corrected reticulocyte count or reticulocyte index, which means there is a formula for that. Whenever you want to know that, you are going to take something called the actual reticulocyte count you are going to get in the peripheral smear multiplied by your actual hematocrit of the patient. Your actual patient's hematocrit divided by the normal hematocrit, which is very important. So if you take this example, what we have seen here and apply in this formula, so you can clearly see that the reticulocyte count here is 2.5% multiplied by the actual hematocrit of the patient is 15% and the real hematocrit is approximately, the normal hematocrit is 45% you can take, which can be taken relatively normal. So 1 divided by 3 and 2.53 goes, it's approximately only, you're going to get maybe 0.8%, which is not at all a good response. For example, if you ask a corrected reticulocyte index, what is a good response, good erythropoietic response in the bone marrow, then you can tell if it is more than 3. If it is poor reticulocyte response, you can tell it is less than 2. So here you can clearly see it is definitely less than, your 3 value. So definitely this is not a good reticulocyte response. So it's a poor reticulocyte response. With respect to the degree of anemia you're encountering in this patient, definitely this is not something right. So definitely this is how you find out the correct resolution. And definitely next thing what you have is something called a reticulocyte production index. This is the next thing that's called a reticulocyte production index is there. So what do you mean by reticulocyte production index? It's very simple. You have something called corrected reticulocyte count, that is called reticulocyte index divided by something called a reticulocyte maturation time. Here something called a reticulocyte maturation time in days. It's approximately 1.5 to 2 days, isn't it? That's called reticulocyte maturation time. So in the previous example, if you ask me, the corrected and the reticulocyte production index is still low, that is approximately only by if you take 2 divided by 2 on this reticulocyte maturation time, so it's going to be only hardly 0.4%. So which means again, if it is less than 3, I can tell it's a poor response. If it's less than 2, I can call it as a poor response, and if it's more than 3, I can call it as a good reticulocyte response. So always whenever you have anemia, don't take the actual reticulocyte count, always do something called a reticulocyte index or reticulocyte production index. So which is actually relatively good because your actual reticulocyte count may not actually reflect the true bone marrow erythropoietic activity in those cases with an anemia, because of the decrease in the number of the circulating RBCs, which may relatively look like as if the reticulocytes are increased in number because the surrounding people are reduced. Because of that, this reticulocyte population may appear a bit increased, and you might have a higher percentage of reticulocytes than what is actually happening in the bone marrow. So be very careful about that. So that is the importance of this reticulocyte count, reticulocyte index, and reticulocyte production index. And finally, you have something called another last index, that is called the red cell distribution width. Whenever you think about the red cell distribution width, it is a measure of something called your anisopoikilocytosis. It is a measure of anisopoikilocytosis. That is what we refer to as something called red cell distribution width, which is a variation in the size and the shape. The normal red cell distribution width is in the range of 13 to 15%. This is the normal red cell distribution width. So red cell distribution width can be naturally be either increased or it can be normal. I don't think there is a condition that can reduce the red cell distribution width, but it can be increased or it can be normal. So if they ask you where the red cell distribution width is increased, classically you have to tell 2 conditions in exam. One is your iron deficiency anemia. Second one you might get in a megaloblastic anemia. In these 2 conditions, definitely the red cell distribution width will be increased. But you can actually tell 2 other conditions. For example, in a hemolytic anemia, also you can tell in a thalassemia major. But even though only few books tell that, but it's true actually. The anisopoikilocyte is actually more in a major. But whenever I tell the red cell distribution width is normal, you have to tell 2 classic conditions, that is anemia of chronic disease, and second one is thalassemia minor. Definitely not major. In a minor, your red cell distribution width may be completely normal in nature. So this is what is the 2 most important things that you have to know about the red cell distribution width. So whenever it's increased, think about iron deficiency anemia and megaloblastic. Whenever it's normal, think about anemia of chronic disease, maybe a thalassemia minor. So these are the conditions where the red cell distribution width may be increased or normal, which means in iron deficiency anemia, megaloblastic anemia, there will be a lot of different sized RBs will be there, whereas in anemia of chronic disease and thalassemia minor, the red cells may look little bit same in shape and size. So there won't be much variation. If RDW is normal in the sense, there is not much variation in the shape and size of the RBCs. That's what it's going to tell you. The next thing what we are going to discuss is on the classification of this anemia by morphology. So how can you classify anemia by morphology? So the classification of anemia by morphology, the first thing you need to know is about the microcytic, normocytic and macrocytic anemia. So this is the basic classification of any anemia for that matter. So whenever you have a classification in exam related question, you have to first classify into a microcytic, then you have to classify into a normocytic, then you have to classify into a macrocytic anemia. So if you ask me about microcytic, I can tell MCV must be less than 80, normocytic in the sense 80 to 100, and macrocytic means more than 100. So that is the difference between microcytic, macrocytic and normocytic anemias. So if you ask me the etiology, which is again relatively more important, the etiological aspects. So if you know the pathophysiology properly, you can tell the etiology properly. If you ask me what is the pathophysiology of microcytic anemia, the answer is reduced cytosolic hemoglobin. Reduced hemoglobin is the reason for microcytic anemia. The moment if you know what all causes the reduced hemoglobin. So first you can see where the hemoglobin comes from. So if you ask me where the hemoglobin comes from, it comes from two sources. One is from the globin and second is the heme. So these are the two things that mix together to give the hemoglobin. So which means either reduction in the globin or reduction in the heme is going to reduce the hemoglobin, which is going to ultimately going to result in a microcytic RBC, microcytosis. Fine. So reduction in the globin, you know very well what is a disease. That is what we refer to as something called a thalassemia. And reduction in the heme is something quite different. Whenever you have a reduced heme, you can tell where the reduced heme is coming from. Because heme itself is synthesized from two sources. One is from the iron and second one is from your protoporphyrin ring. Protoporphyrin. These are the two things that are essential constants of the heme. So whenever you have blockade in the protoporphyrin synthesis, for example in a sideroblastic anemia, I mean obviously you are going to get a microcytic RBC. Similarly, if you have a blockade in the iron utilization or iron supply, then you might get poor heme production, because that you might get a microcytic RBC because of low hemoglobin in the cytosol. So what are the conditions where you have a poor iron supply or poor iron utilization? Two things, very simple. One is in iron deficiency anemia and second one is anemia of chronic disease. Iron deficiency anemia, it's the deficiency of the iron, that's the reason for the poor supply of the iron. But whereas anemia of chronic disease, we are going to discuss in detail in the iron metabolism section. But to be honest, the reason in anemia of chronic disease is iron is there as a storage form, but it is not released because the inflammation blocks the release of iron from the storage and also prevents the absorption of iron from the intestine. It's a functional iron deficiency rather than a true iron deficiency. That's what anemia of chronic disease or chronic inflammation is going to create. So anyway, in both these conditions, this is the problem. So this is the reason why. So these are the four classic conditions where you're going to get a microcytic RBC or a microcytic anemia. So these are the etiologies of microcytic anemia. Apart from that, many people do forget copper deficiency. Yes or no? This copper deficiency also can result in a microcytic RBC. Apart from that, other things are not that important, but these are the four classic things, that are important for the causes of etiology of a microcytic anemia. Then what do you think about a normocytic anemia? In a normocytic anemia, typical first thing, I'm going to divide into three causes. One is hemolytic causes. Lot of hemolytic causes are the first hemolytic causes is hemoglobinopathies. We are going to discuss a lot on this hemoglobinopathies. You have sickle cell disease, HBC disease, so many things are there. Second thing, we are going to discuss on enzyme deficiencies. Lot of enzyme deficiencies, again you have pyruvate kinase deficiency, phosphofructokinase deficiency, G6P deficiency. Lot of enzyme deficiencies can result in hemolytic anemia. We have separate classification for that later on. Then you have membrane defects. Membrane defects, again it's due to hereditary spherocytosis, hereditary elliptocytosis, again similar conditions. Then you have autoimmune hemolytic anemia where the direct Coombs test will be positive. Then you have microangiopathic hemolytic anemia where you include HUS-TTP complex as well as the DIC, disseminated intravascular coagulation. Then you have a macroangiopathic hemolytic anemia where the problem is the blood RBC circulating through a rigid metallic structure like dialysis circuit or maybe through a prosthetic valve or whenever you place a LVAD device, left ventricular assist device. Or it could be infections like malaria, Babesia, and all these infections may cause hemolysis. Even Clostridium septicum can cause hemolysis, sepsis or sepsis from a Clostridium species can cause hemolysis as well. But anyway, we are going to tell next the non-hemolytic causes. The moment you think about this non-hemolytic causes, non-hemolytic means the first classic cause is aplastic anemia. This is a classic cause. But remember, what is the only difference between a hemolytic and non-hemolytic cause? In hemolytic causes, the reticulocyte index will be more than 2%, which means definitely the bone marrow response will be good because it's a peripheral destruction. To compensate for that, the bone marrow is going to produce excess number of RBCs and the reticulocytes. Whereas in the non-hemolytic, reticulocyte index will be less than 2%, where the bone marrow response is going to be poor. Plus, if you want to remember, you can remember iron deficiency and anemia of chronic disease also. Wait, come on. Sometime back you told that your iron deficiency and anemia of chronic disease is going to cause a microcytic RBC. Now you're telling it's a normocytic RBC. What's happening over here? Simple, in early stages. In early stages of iron deficiency anemia of chronic disease, you're going to get only a normocytic RBC. Later on, you might get a microcytic RBC, but microcytic is classic. Don't tell in exam you're going to get a normocytic as well as microcytic. Iron deficiency and anemia of chronic disease means it's a microcytic RBC only. In early stages, you might, in rare case, you might encounter a normocytic anemia. But apart from that, third thing what I'm going to tell is a recent blood loss. For example, after surgery, after traumatic hemorrhage, or maybe after GI bleed, like recent blood loss, you're going to get a normocytic anemia only, which is not going to affect the RBC size at all, where the reticulocyte index again will be more than 2%, which means there will be a good reticulocytosis from the bone marrow. So the classic example is aplastic anemia here. Then macrocytic, you have a huge differential for macrocytic. Basically, I generally tend to divide into megaloblastic macrocytosis, and second thing you can tell is something called a non-megaloblastic macrocytosis. So what is the difference between a megaloblastic macrocytosis and a non-megaloblastic macrocytosis? The moment you call about a megaloblastic macrocytosis, it is due to impaired DNA synthesis, or is due to impaired DNA repair or impaired DNA maturation. You can tell in any way it's impaired. So where here it is normal DNA synthesis, normal DNA maturation, normal DNA repair, all these things tends to be normal here. And if they ask you where you see hypersegmented neutrophils, and I am going to discuss with an image a lot of details on the vitamin B12 and folate deficiency topic. But still, hypersegment neutrophils typically characteristically means any neutrophil with 6 or more lobes is what we called as nuclear lobes is what we called as hypersegmented neutrophils, which is a typical feature of a megaloblastosis, which is not seen in a non-megaloblastic macrocytosis. Last but not the least, for example, if you take the MCV more than 120 femtoliters is possible in case of a megaloblastosis, whereas it's typically in the range of 100 to 110 in case of a non-megaloblastic macrocytosis, which means in a non-megaloblastic causes, your MCV will not exceed this 110 mark usually. 120 mark and above is typical of a megaloblastic anemias. But if you now know the etiologies, so you have to now know the etiologies. What are the etiologies? Number one, the classic B12 and folate deficiency that tends to be the most common cause in India, at least for the megaloblastic anemia, megaloblastosis. Second, you have something called your myelodysplastic syndrome, otherwise called MDS. Third one, you have something called your orotic aciduria. These are rare causes. You have something called orotic aciduria. And fourth one, you have something called a Fanconi anemia. And number 5, you have something called a TRMA. That's called thiamine responsive megaloblastic anemia. So what do you mean by thiamine responsive megaloblastic anemia? Because the name itself suggests this megaloblastic anemia is thiamine response, which means it responds to high doses of thiamine in the first place. If they ask you what is the defect is in the SLC19A2. So this is the thiamine transporter into the cell. So because of the mutation of the thiamine transporter gene, that is SLC19A2. So because of that, you might be getting a disease called thiamine responsive megaloblastic anemia, where the classical features of this patients will be they present at infantile age group itself. The infant will come with severe anemia, that is megaloblastic, and the infant may be diabetic as well. At the same time, the infant may be having a very early sensorineural hearing loss. If they ask you the treatment is high dose thiamine, where typically it responds to that high dose thiamine. Finally, the best comes at the last, the drugs, which are very important. There are 2 types of drugs that can cause megaloblastic picture in the peripheral smear. So the first group of drugs is the drugs that induce megaloblastosis by themselves, because they directly affect the DNA maturation and the DNA repair and DNA synthesis. Whereas the second group of drugs, they do not cause directly megaloblastic anemia, but indirectly by affecting the B12 or folate metabolism or both. So in this condition, you might get a megaloblastic anemia due to drugs as well. So number 1, if it's due to drugs, the first one I can tell drugs that induce megaloblastic changes, or second one, the drugs that interfere with B12 and folate metabolism. What are the drugs that induce megaloblastic changes by interfering DNA maturation and DNA synthesis. First one is the azathioprine, classic drug. Second one is the 5-fluorouracil and 6-mercaptopurine. All are anti-cancer drugs. Third one you can get with cladribine, and fourth one you can get with hydroxyurea, and fifth one you can get with maybe certain NRTAs, of which the most important NRTA that causes this is zidovudine, that is azithromycin, AZT. Probably a little bit with lamivudine, which is written as 3-TC, and it can also happen with trimethoprim because it inhibits DHFR. Obviously, like that folate related metabolism is affected. Seventh one, it also can be caused by nitrous oxide. It can also be caused by methotrexate and mycophenolate mofetil. It can also be caused by pentostatin, and it can also be caused by allopurinol, your favorite in gout and chronic hyperuricemia, allopurinol. So out of which you have to filter it. What are things that are very important? Zidovudine, definitely important. Nitrous oxide. I don't know why multiple times asked question in anesthesia as well. Nitrous oxide inducing a B12 deficiency. And then you can tell hydroxyurea, very, very, very important, which can directly induce it, and probably an azathioprine. So remaining, you might remember or you might not remember. So all these things are really, really important. So what are things that interfere with the B12 and folate metabolism? Again, number one, you can tell first is phenytoin. Number two is metformin. If somebody asks you what are the two most important drugs in this group, it's these two. That's it. Phenytoin, metformin. On long run, they can induce B12 deficiency. And third thing, which is increasingly asked in the recent exams, is on the octreotide. Probably on the octreotide. And it might happen with some drugs like cholestyramine and with certain antibiotics. So what are antibiotics? Probably you might get with erythromycin, you might get with ampicillin, you might get with nitrofurantoin, you might get with tetracyclines, or you might get with the chloramphenicol. So these are some of the conditions where you can get a megaloblastic anemia, out of which these two interfering folate and B12 metabolism, your phenytoin, metformin tops the chart with a little importance to octreotide as well. At the same time, what are the conditions that produce non-megaloblastic macrocytosis? Again, a lot of conditions are there that can produce non-megaloblastic macrocytosis. For example, if they ask you the most common cause for non-megaloblastic macrocytosis, your answer must be alcohol. That's it. This is supposed to be the most common condition that produces non-megaloblastic macrocytosis. Apart from that, you might get with a liver disease, you might get with a scurvy, that is due to vitamin C deficiency, you can get with a hypothyroidism, you can get with a condition called multiple myeloma, you can get with patients who have undergone bariatric surgery, post-bariatric surgery, again it's very common, and you might have with Down syndrome. You might have in certain rare conditions like Diamond, Blackburn anemia, or you might get in condition like post-splenectomy also, after splenectomy also you might get. So these are the conditions. Out of this, if you filter and see, the most important are the Down syndrome and alcohol. These are the most important things that you have to know that can induce a non-megaloblastic macrocytosis in the first place. So this is something called a non-megaloblastic macrocytosis. Out of this, your bone marrow failure syndromes. What I want to tell is, even though this classification is there, but there are certain conditions like, especially the bone marrow failure condition states like aplastic anemia, MDS, then you have myeloproliferative disorders. In these conditions, the anemia can be either normocytic or even a macrocytic. So it can be either normocytic or macrocytic. Very, very important. So you cannot tell really it's macrocytic only, but majority of times, for example, in MDS it tends to be macrocytic, in aplastic anemia it tends to be normocytic, but majority of the times, not always, but they can be either normocytic or macrocytic in these patients. Similarly, there is one spurious cause of macrocytosis is there, you have to know about what is the spurious cause of macrocytosis. The answer is if the patient is having underlying reticulocytosis. Patient is having underlying reticulocytosis because the automated machines count the RBC and the reticulocyte in a similar way because both do not contain the nucleus. So they mistake the reticulocyte for an RBC. Since the reticulocyte is actually a bit larger compared to the RBC, we have seen in the erythropoiesis basic section itself, reticulocytes are a little bit bigger in size compared to the RBC. So an MCV, since they are mistaking the reticulocyte for the RBC, the average size when you take it might show some discrepancy, it might show a falsely increased value because the reticulocyte itself can cause a spurious increase in the MCV value. So I think with this we are completing your basics of anemia section. In this we have dealt about the definition of anemia, the criteria for diagnosing an anemia, then the various RBC indices and reticulocyte count and all this stuff. At the same time we have discussed how you classify anemia in a morphological basis into microcytic, normocytic and macrocytic, and what are the basic underlying pathophysiological reasons for getting all this classification and anemias behind them. And in the next video we'll be discussing on more of iron metabolism and probably iron deficiency anemia.